Thank you. Good morning, good afternoon, good evening, everybody. I would like to thank you for the kind invitation. So basically, I will be summarizing my presentation at the EBMT meeting on monoclonal antibodies and Hodgkin lymphoma. So as you know, Hodgkin lymphoma is a unique disease in that relapses can be salvaged heading to cure in more than 50%. And the standard of care for a patient with Hodgkin lymphoma failing first-line therapy is salvage chemotherapy followed by autologous stem cell transplant. And basically, different combination chemotherapy were tested in terms of salvage. They are quite comparable with around 30% complete remission rate and 70% overall response rate. And it is better to be in complete remission before transplant. And actually, as you know, we have monoclonal antibodies that have recently changed the landscape of Hodgkin lymphoma. These are Brentuximab vedotin targeting CD30. So it's an anti-CD30 monoclonal combined with carrying a chemotherapy product. And we have checkpoint inhibitors, particularly Nivolumab and Pembrolizumab, that are quite efficacious. And to summarize my talk, basically these new drug combination-based salvage therapy before autotransplant have tremendously increased the rate of response and complete remission. So basically, when you combine Brentuximab vedotin, for example, with chemotherapy in patient failing first-line treatment, you have around 90% response rate, 70% metabolic CR. So it's more than doubling the rate of complete remission before transplant with outstanding PFS post-transplant. And also these monoclonal antibodies can be used in addition to a salvage pre-transplant. They can be used as consolidation after autotransplant to prevent relapse. And we have both the ATHERA study for Brentuximab vedotin and a new phase 2 studies for checkpoint inhibitors alone or combined with BV that are quite promising. However, not all patients do well after autotransplant. So those who relapse after auto can respond to Brentuximab vedotin, can respond to checkpoint inhibitors. However, few of them will be cured without allotransplant. So allogeneic transplant remains a potentially curative strategy for patients who fail autotransplant. However, monoclonal antibodies are quite useful as bridge to allo, allowing patients who relapse after auto to respond again so that they are able to undergo allogeneic transplant. And both Brentuximab vedotin and checkpoint inhibitors can be safely used before allotransplant or even for relapse after allotransplant. However, we should be cautious when using checkpoint inhibitors. We need at least 2 months before allo and at least 6 months after allo as a window where we should not be using checkpoint inhibitors to avoid severe graft versus host disease. And so currently with these results, the overall survival after for patient relapsing after auto has significantly increased in recent years. And this is a presentation that we made at the last ASH meeting, and 4-year survival increased from 30% for patients who relapsed 20 years ago to above 60% for patients who relapse in the recent years. And this is a great hope for Hodgkin lymphoma patients.